the oncology section. Well, the most common cause of cancer death in the United States is lung cancer. That's for both men and for women. Which cancer screening method is most likely to lower mortality? Of all the cancer screening methods, the one that's most likely to lower mortality is mammography. Now, it's controversial between 40 and 50. It's definitely going to help after the age of 50. Remember, there's 250,000 cases a year of breast cancer in the United States. So when you screen 1,000 50-year-olds, you find far more cancers than you find in screening 1,000 40-year-olds. And the reason that it's controversial is that we don't understand that doing a biopsy and doing MRIs and sonograms and lumpectomies for people who are 40 that don't really have breast cancer is a major source of morbidity that's really quite problematic. So when you do mammography or you feel a lump or you feel the lump, then the answer is to do here, even if you feel the lump, you do a mammogram first. Why do a mammogram first if you already feel a lump in the breast? The answer is a small number of people, 10%, have 2 sites in the breast, and they also have contralateral or bilateral disease. So why am I doing mammography in people who I feel a lump on? Because you might have 2 sites of cancer in the same breast, which means you can't do a lumpectomy. You see, if you have a single site and it's unilateral in one breast, lumpectomy, cutting out the lump with radiation therapy is just as good as doing a modified radical mastectomy. But you can't just do a lumpectomy and radiation if you've got multiple sites within the same breast or you've got disease on the other side in the other breast. Here's other things that are very clear. It's very clear that mammography is best above 50. At 40, it might be okay, but at 50, it's best. It's very clear that breast self-exam is a very nice idea. Breast self-exam about feeling for your own lesions is a wonderful idea. It just doesn't help. This is hard for people to understand. Why not do it? Well, because it distracts you from doing the test you really need, which is a mammogram. Number 2, it misses lesions that are already small. And the other thing is it's just not accurate enough. It lulls people into a false sense of security. The short answer is it doesn't lower mortality, it doesn't help. So breast self-exam is out. If you feel a lump, you still do mammography before you do the fine needle aspiration or the core needle biopsy. Because the fine needle and the core needle biopsies deform the breast. They have some effect on the breast that make the mammography less accurate. So the fine needle aspiration, the core needle biopsy, the fine needle aspirate is less complicated, less bleeding, less deformity, and less accurate. The core needle biopsy is more complicated and more accurate. More complicated and more accurate, more sensitive, more specific is the core needle biopsy. Why not just do the needle biopsy first? Because 10% of people have more than one site in the same breast. 10% of people have bilateral disease. Mammography is needed to know before you do the biopsy whether or not it's in multiple sites or bilateral, because the biopsies themselves deform the tissue that makes the test, the mammography, less accurate later on. Now, once I know that I have breast cancer, I want to know, 1, is there metastasis to that disease? 2, is there lymph node involvement? 3, what is the size? 4, is there estrogen receptor, progesterone receptor positive? Estrogen receptor, progesterone receptor positive. 1, is there metastasis? Because if there's metastasis, there's no point in just doing a lumpectomy if there's metastasis. If there's metastasis, we can give chemotherapy. If there's metastasis, you might radiate some things, give chemotherapy, but there's no point in just taking off people's breasts if there's metastasis. Next, if there's lymph nodes involved, lymph nodes involvement gets adjuvant chemotherapy. Lymph nodes involvement tells you about prognosis. Next, the size of the lesion. Lesions above 1 centimeter, larger lesions need chemotherapy. Larger lesions tell about prognosis. They don't tell as much about prognosis as lymph node involvement, but they tell you, do you need chemotherapy and what's the prognosis of that disease? Estrogen and progesterone receptor, either one of those tell you, do you use aromatase inhibitors? Do you use selective estrogen receptor modifying medications? Tamoxifen, naloxone, or aromatase inhibitors? And that can be obtained on the biopsy. Here are some other tests. Next, ultrasound is used when you're not sure, is this a cystic versus a solid lesion? Ultrasound can tell you cystic versus solid lesion because cystic lesions are more likely to be benign. Ultrasound. Next, MRI is used sometimes when people, it's not really actually super clear when to use MRI, but people who have dense breasts, people who have very solid breasts, MRI, it's not super clear about when to use the MRI. PET scanning, positron emission tomography, PET scanning can be used when you might have lesions elsewhere, other lesions, and you want to be able to say, are they cancerous? Is there cancer in their other lesions? Or are they just anatomically enlarged lesions? That's what PET scanning is for. Positron emission tomography. And that's not just for breast cancer. That's for lung cancer, for lymphoma, and for other diseases. For lung cancer and lymphoma, and I want to know, is there a cancer in that other lesion? Or is it just lesions that are solid tumors somewhere else? PET scanning is a way of being able to tell the content of lesions without having to biopsy them. MRI is for dense lesions. Sonogram is for cystic lesions. So, we don't know what causes breast cancer. Mammography is controversial between 40 and 50, so I doubt they'll ask you. If they do ask you something, they'll ask you something that everyone can agree on, which is that it's most beneficial over 50. When should you start? Well, it's best after 50. Nice answer. So when you have a lesion, biopsy that lesion after the mammogram, so the mammogram is not damaged, body biopsy. Mammogram, then biopsy. So what would you ask you? You'd ask about things that are definite. And it's definite that breast self-exam does not help. It's definite that if you have lymph nodes that are positive for disease, you need adjuvant chemotherapy, and it tells prognosis, and you should radiate the axilla. If you have lymph nodes that are positive in the axilla, you should radiate the axilla. The size of the lesion, the larger the lesion, the more likely it is to metastasize. And if you have either estrogen or progesterone receptor positive, you should use aromatase inhibitors, anastrozole, letrozole, anastrozole, letrozole, or selective estrogen receptor modifiers, which is tamoxifen, naloxone. So now we're going to summarize the things that lower mortality in breast cancer. And it's going to show you a huge difference between this and prostate cancer. In prostate cancer, there's only a radical prostatectomy. In breast cancer, there's lumpectomy and radiation. There's modified radical mastectomy. In prostate cancer, there's no hormonal therapy to prevent metastasis. There's hormonal therapy once metastases have occurred. In prostate cancer, we don't have any good chemotherapy. In breast cancer, there's a lot of good chemotherapy. So what lowers mortality? We have several surgical procedures that lower mortality. Modified radical mastectomy, lumpectomy, and don't forget the radiation, because if you don't radiate the breast, it recurs at the site of the breast. You have things that manipulate the estrogen and progesterone receptor modifiers. You have selective estrogen receptor modifiers, tamoxifen and raloxifene, and the aromatase inhibitors. And the aromatase inhibitors and estrogen receptor modifiers both lower mortality. If you have people who have positive lymph nodes or above 1 centimeter size, positive lymph nodes above 1 centimeter in size, positive lymph nodes are greater than 1 centimeter in size, positive lymph nodes are greater than 1 centimeter in size, we have chemotherapy to prevent it from recurring. We don't have good chemotherapy for prostate cancer. We have a lot of hormones for prostate cancer, but none that prevent metastasis. There's a number of things that prevent metastasis in breast cancer. Tamoxifen, raloxifene, anastrozole, letrozole, aromatase inhibitors. We have surgical procedures, hormonal procedures, chemotherapeutic procedures, trastuzumab, anti-HER2/neu. We have monoclonal antibodies that stop the proliferation of the disease. So in breast cancer, we have multiple surgical procedures that prevent propagation of the disease. Modified radical mastectomy. Radical mastectomy is never correct and hasn't been for 40 years. A lumpectomy, don't forget the radiation. Hormone therapy, chemotherapy, and monoclonal antibodies. So we have multiple modalities to prevent metastasis in breast cancer, none of which are useful for prostate cancer. Last point. In the prevention of breast cancer, which I'll put over here because it's not treatment for breast cancer that's occurred, if you have two first-degree relatives, in other words, you have a sister and a mother, two sisters, a sister and a mother and a sister, two sisters or two mothers, two first-degree relatives, you should get BRCA testing to tell you if you're at increased risk. This is a very difficult test because it does not mean that you should automatically be referring people to bilateral mastectomy. It personally drives me batshit crazy when medical students and residents say that. What you should do is be able to inform people. You're at a high risk of breast cancer. You have a 50 or 70% chance of breast cancer. You might choose to do a bilateral mastectomy. You might choose to do this other therapy which prevents breast cancer. What's this other therapy that actually outright prevents breast cancer? Tamoxifen. Tamoxifen and raloxifene outright prevent breast cancer. You may choose to do a bilateral mastectomy, but these drugs decrease the risk of breast cancer in people who are BRCA positive, and especially those who have multiple first-degree relatives. Multiple first-degree relatives gives a 40%, 50%, 60% chance of developing breast cancer just by having multiple first-degree relatives. Siblings and mother, and siblings and mother, and siblings and mother. Multiple first-degree relatives gives a 50, 60% chance of breast cancer. BRCA is this should be done on. What does BRCA add if you already know in advance that you already have a 50% chance of breast cancer? Well, not an enormous amount, but it's not our place to judge. When is it the answer? Multiple first-degree relatives. What does it mean? A high likelihood of developing breast cancer. What does it add? I can't answer that question. Because you already knew before you did the test that the person had a 50-50 chance of breast cancer. Tamoxifen and raloxifene decrease that risk by half. Tamoxifen and raloxifene decrease that risk by half. But mastectomy, bilateral mastectomy, decreases it almost entirely. But we can't answer that question. I'm very specific about this because I ran into a conflict with a surgical teacher once And he said, BRCA means you should have bilateral mastectomy. Like, really? Automatically? It's kind of harsh. Like, oh, by the way, what do you do for a living? Oh, I'm a breast surgeon. Oh, I like that. So this test means for you, referring people to you to have their breasts cut off. We're going to have to bear the uncertainty. Your test is not going to ask you something that's not definite. BRCA means you have a high risk of cancer. You may choose to do bilateral mastectomy. Tamoxifen decreases your risk by 50%. That's it. Last point. Sentinel node biopsy. The sentinel node is the first node in the operative field. You put a dye or contrast into the operative field. And when you take out the breast, that's the first node. And if that first node has cancer, you should do the axillary lymph node dissection. Because the axillary lymph node dissection means you'll radiate the axilla, give chemotherapy, and determines prognosis. You'll radiate the axilla, you'll give chemotherapy, it determines the prognosis. If the first lymph node is negative, you don't have to do the axillary lymph node dissection. Sentinel node, what is it? It's the first node in the operative field. What does it mean? If it has cancer in it, you should dissect the axilla. If it doesn't have cancer in it, you don't have to dissect the axilla. Look at all the great things we could do with breast cancer we couldn't do before. You have 4 different classifications of mortality benefit and multiple things in each one. Modified radical or lumpectomy and radiation, estrogen receptor modifiers or aromatase inhibitors. Yes, aromatase inhibitors prevent more cancer, but they also cause osteoporosis because they block estrogen everywhere. They're called tamoxifen and raloxifene, selective estrogen receptor modifiers because they're agonistic on the bone, but antagonistic on breast cancer. Chemotherapy, if there's nodes positive or large lesions, and anti-HER2/neu blocks the cancer in those who express this extra antigen, it blocks the cancer. Look at all these things we can do. These didn't just happen. Look at all the fantastic things we can do to help people. It's great, man. It's great. It's great. Look at all the great things we can do. It's great. It's great.